I thank the chairperson and the moderator and the expert panelists for a very informative and a nice first session. We shall now proceed with the second session of the day, which will be on STEMI. The chairperson of this session are Dr. D.P. Sinha, Dr. Ranjan Sharma, Dr. Sunil Lilha, and Dr. Jamal Yusuf. The session will be moderated by Dr. Shankar Mandal, and the expert panelists for this session are Dr. Bimlendu Kumar, Dr. Anupam, Dr. K.D. Singh, and Dr. Amit Gupta. I'll request the chairperson and moderator to take the proceedings further. Thank you so much.
Good evening, everybody. I'm Dr. D.P. Sinha. I now invite Dr. Dhiman Kahali, who doesn't need any introduction in the current gathering. He's an eminent cardiologist, one of the top cardiologists in Calcutta, to proceed with his discussion on thrombosuction in acute MI. Dr. Kahali, please. Dr. Kahali, you are muted. You are muted.
Okay. Thank you, Professor DP, for your kind introduction. And thanks the chairpersons. I must thank Dr. Dilip Kumar, Dr. Shunandan Shikdar, Dr. Devabrutu, and Dr. Mrinal Das for inviting me to speak on the occasion. And I have been asked to talk on thrombosuction in acute MI. And we know that it has recently been downgraded to a great extent. So, these recent trends, as we see in the guidelines, they have been downgraded. And we also know of the fact that acute MI caused by thrombotic occlusion of native coronary arteries. And it's very important that the IRA should be readily fixed if somebody has got an acute MI. And partial occlusion causes an STEMI, and complete occlusion causes STEMI. And occlusion of SVG lesion has large thrombus burden. And yesterday we had the occasion of seeing how they operate on the SVG grafts when they are thrombosed. But one should remember that SVG grafts always contain lots of thrombus, and a protection device should be put before doing whatever we want to give, that is aspiration and other things or whatever we want. And stent thrombosis is very important. This is an important cause of MI nowadays. Just to give some data from US, in 2003-2004, the incidence of stent thrombosis causing MI was only 6%. But in 2009-2010, the NRMI data showed that it is as high as 11%. That means it's 200% increase in the incidence of stent-related MI. And success rate of recanalization of IRA, whatever mode we give in primary PCI, is more than 90%. So that's fascinating. But in case of stent thrombosis, the rate is only 75 to 80%. And it needs further knowledge on our part and further modification of the procedures what we have been doing in case of PCI related to stent thrombosis. And of course, with the Jotarelumus and everolimus eluting stent, the incidence of late stent thrombosis is very late, but still we do get cases. And if we do get, the results are only 75 to 80% according to all the literature. And it's very important also to open up the artery as soon as possible. And non-ST resolution is associated with 29% long-term mortality, whereas complete ST resolution, the long-term mortality is only 4%. So it's seven times higher if we can't open up the artery properly. And we also want to tell you that in epicardial artery opening of the IRA, even if it shows TIMI3 flow, that DASH last 3, we get in only 30% of the patient. In 70% of the patient in the IRA, there is TIMI-3 flow, but the TIMI blush is only 0 to 2. So it's very fascinating that if we can open the artery completely, the mortality and other things are much, much less. And also, if there is blush is 3, the mortality is only 3%, and it is 23% if the blush is 0 to 1. So these are very important. Coming to our topic, these are the various gadgets we employ, and anybody can teach me on this. Export catheters and also quick cal expressway. These are obsolete nowadays. Phase 2, Pronto LP, Pronto 3, Pronto 4. We have used a lot of Prontos, but nowadays we use less of these materials. And these are the angiojet Distaflex, angiojet Spiroflex, and the third one, angiojet Spiroflex VG. We haven't got any of this in our city or in the eastern part, I think. I don't think it's in the country now, rheolytic angiojet. And in rheolytic angiojet, this is the console you can see, and thrombus is evacuated from the body and into the collection bag, as you can see. And this is the console, and saline jet travels to create a low pressure zone, causing a vacuum effect. And at the tip of the catheter of the rheolytic system, the pressure is as low as minus 600 millimeter. So there's a strong jet which carries the thrombus from the site of lesion, and thrombus is drawn from the inflow windows, and the jet pushes the thrombus back down the catheter. And we should know also that in the aspiration thrombectomy, it is only minus 10 millimeter. And this is a case where you can see that the SVG is completely occluded. We can see the stent also. And by aspiration thrombectomy, this is the result with, TIMI 1 to 2 flow. And we don't want this kind of flow. So there was rheolytic thrombectomy done. And this is the result after rheolytic thrombectomy. And I remember Patrick Service speaking 7 to 8 years back in a EuroPCR session in a big room, that it has reduced mortality by 4.5%. But that's all history now. And we should remember that these are the data which just now I mentioned. But the degree of blood loss is same with both the rheolytic system and aspiration. Though the negative vacuum is much more with the rheolytic system, there is no excess bleeding with it. But these are all histories now. Hardly anywhere it is used, rheolytic angiojet. And some patient requires TPI during thrombectomy, especially of the right coronary artery. Sometimes following aspiration, angiojet is used very, very rarely, especially in case of venous grafts, and rheolytic thrombolytic catheters are no more recommended by any of the guidelines. ACC, HA, ESC, SCI, nothing. LMC, a large thrombus, always requires aspiration thrombectomy. Just I am giving you opposite picture. This is by none other than Antonio Colombo in 2020. And embolic devices, protection devices should always be put in case of SVG intervention, because they contain huge, huge thrombus, and we don't want to intervene in cases of SVG related MI. Now, these are some of the trial data I should mention. TAPAS trial, it is one of the first with 1,057 odd patients. And aspiration thrombectomy versus conventional PCI was considered. An aspiration done with export catheter. An aspiration thrombectomy is associated with marginal improvement with recurrent MI and TLR, with no improvement in the infarct side, and not to tell of reduction of any mortality. This was the second and the largest test trial till date. It included 7,000 odd patients. This trial failed to document any mortality benefit in the aspiration thrombectomy group, but aspiration thrombectomy reduced recurrent MI, but p-value was not significant, 0.09, and stent thrombosis at 30 days, it was non-significant, 0.06. Long-term follow-up data of test shows similar results, and total also shows the third one, total trial, it also shows the similar results, and total demonstrated the routine thromboaspiration during PCI for patient STEMIs, with which was done at an increased risk of stroke during 1 year. So this is very disturbing. This total trial showed that there is a peak of stroke incidences after aspiration thrombectomy. These findings thus providing evidence for beneficial effects of no beneficial effects of aspiration thrombosis opposite to the findings, and due to the controversies, recommendation of routine thrombectomy has been incrementally downgraded from class 2A to 3 in the most recent guidelines. Just to show the guidelines, this is the 2013 ACCHA guideline. You consider manual aspiration thrombectomy reasonable in patients with STEMI. This was class 2A, but this is history now. Undergoing PCI, aspiration thrombectomy is an indication in primary PCI setting. You see the next one, 2014. The same recommendation was from 2012 ESCTS recommendation that it should be a normal one during PPCI. But see the 2014 downgrading suggests that routine use of manual aspiration thrombectomy is not essential in patients with STEMI undergoing PCI. Selected use may be useful to improve TB3 flow to prevent stent thrombosis. Routine aspiration thrombectomy before primary PCI for patients with STEMI is not recommended. And this is the 2015 ACC Sky joint document. There are insufficient data to recommend this as a routine intervention. This is aspiration thrombectomy class 2A recommendation in ESC 2012, and you can see what was the 2017 recommendation, that it is not recommended as a routine procedure in these patients. Next, I come to a trial which was presented with much fun and fair in EuroPCR 6 years back, followed by an ACC TCT. Infuse AMI trial, 4 groups, abscissa plus aspiration thrombectomy, both in one group, aspiration thrombectomy only, and third group abscissa only, and fourth group no abscissa. Very interesting results. Aspiration thrombectomy didn't reduce final infarct size. At 30 days, local delivery of abscissa associated with reduced infarct size 0.03. At 1 year, compared with no acute therapy, local delivery of abscissa lowers death 1.4% versus 4.9%. But we should mind that it was given intralesionary by a clear-way catheter, which is a 2.7 French catheter with a terminal bore with which the drug is infused locally, and it acts very well in comparison to the IV or intracoronary delivery. So these all were compared with the clear-way catheter being injecting the drug intralesionally with aspiration thrombectomy associated with lesser new onset heart failure. So it's very interesting, 0.9% versus 0.4, 0.2, and hospitalization for heart failure was similarly reduced. So this is a paradigm shift to the previous knowledge. And I think this all data can tell that at present, aspiration thrombectomy hasn't got any much role in the primary PCI, but we should not forget that if the artery is a very large one, suppose it's a huge left main thrombus, as I showed, it was advised by none other than Antonio in 2020, and also in case of proximal LAD, huge LAD type 4 or proximal RCA, if somebody feels that we should go for aspiration thrombectomy, it's not absolutely contraindicated. It can be done, but it has been downgraded, and many a times we can do the job without any thrombectomy, aspiration thrombectomy. Rheolytic thrombectomy is totally outdated. It has been taken out from all the guidelines. So to summarize, ladies and gentlemen, aspiration thrombectomy is a very important adjunct, but it has been downgraded by the different guidelines, but still we practice it. I want to tell you, re-emphasize, there is not an absolute contraindication. We can go for it, but if one feels it is required because it definitely reduces the thrombus load by 2-3 passes, we should remember that we should keep the tip of the aspiration catheter at proximal to the occlusion, not we should pass distal to the occlusion. Thank you very much for your kind and patient hearing. Thank you.
That was an excellent presentation from Dr. Kahale, looking at the history and the current status and the final recommendations. That would go a long way to particularly our junior colleagues in properly using the aspiration catheters in their lab.
Dr. Sinha, please unmute yourself, sir.
Vishwajit Mohinder, please start your daily audition.
Now, let me ask one question to Dr. Kahali.
Yeah. Shankar, good afternoon.
Good afternoon.
How are you?
You see,
How are you?
I'm okay. You see, mechanical thrombectomy is gaining importance and interest day by day in cerebral vessels in acute stroke.
Yeah. Yeah.
Why it is downgraded in coronaries?
Because of the results, because we go by evidence-based medicine. And Shankar, as I showed you, that all the guidelines in 2012, it was not long back, it was only in 2012, ESC, ESCT, and also in 2013, that is 8 years back by ACCHA, and that was there till 2015.
I understand.
ACCHA downgraded only in 2018. So this was because of the findings. Let me come. So because there was no reduction in the infarct size, not to tell of the reduction in mortality, they didn't reduce recurrent MI, they didn't reduce the MACE, and they also didn't reduce the TLR. So as it had no virtue, and some of the trials like total trial have shown that there was an increased incidence of stroke, which is very disturbing to us.
Dr. Kahali, the total trial, the stroke is more because you see most of the time that thrombosuction catheter is not within the guide itself. And number two, that's why there may be spillage of some thrombus. Now, I want to know whether there is any basic translational science, why it is important in cerebral vessels, not in coronary vessels.
See that because of the the obstruction in the smaller arteries, we cannot do much. We have to depend on the thrombosuction there, and the results are equally good with thrombolysis. Therefore, if we go for early thrombolysis, and I think the window has been extended much more than acute MI. So it varies from place to place in our body. Like thrombolysis, we have initially told 4.5 hours, which was much smaller than acute MI thrombolysis, which was 12 hours. Now they have extended it up to 9 hours. Okay, if you think you can, guys, go for 9 hours. So there will be changes, and there is a huge thrombus load there, and it's effectively done over there. Here we have other ways, we can go for direct stenting. We can open it up and then, give a good cocktail of dual antiplatelet agents, including the newer prasugrel and ticagrelor and aspirin, and you do the job. And we see the difference. I know personally, I give heparin in the CPC, that's the emergency room, and I get very good flow. It's as good as the second generation thrombolysis. And we had a paper also published in Indian Heart Journal.
Okay.
Majumdar, can you start your derivation?
Yes, as I said, my thanks to Dr. Dilip Kumar, Dr. Sundan Sikdar, Dr. Devbrata Rai, and Dr. M.K. Das for giving me opportunity to speak in this excellent conference. And respected chairperson, moderators, and distinguished audience. My topic is myocardial protection in STEMI. This is slightly difficult topic. Now, in developing countries, the incidence of both STEMI and non-STEMI have increased. Although mortality due to MI has reduced worldwide, there is substantial regional variation secondary to differences in the mode and use of reperfusion therapy. A study conducted by Greg Stone et al. Showed that pivotal importance of reduction of infarct size within 1 hour after primary PCI as a determinant of all-cause mortality hospitalization for heart failure in the first year. Although timely and complete reperfusion is the most effective way of limiting the infarct size and subsequent ventricular remodeling, reperfusion per se adds an additional component of irreversible injury and may come into the final infarct size. The prevention and treatment of lethal reperfusion injury and microcircular dysfunction pose a formidable challenge. Thus, the need for additional cardioprotective strategies to reduce the size and coronary microvascular dysfunction remains the last frontier of reperfusion therapy. Now, this slide shows how reperfusion causes irreversible injury. In one side, there is cardiomyocyte component, there is edema of the cardiomyocyte, calcium overload, MPTP opening, proteolysis, apoptosis, cell death, and irreversible injury. In the another component is cellular vascular component. There is microembolization, impaired vasomotion, edema, leukocyte adherence, stasis, capillary rupture that leads to irreversible injury and also cell death. This slide already I have shown in the previous two components. One is cellular, one is vascular, already I have told. Now, role of pre-infarction angina. Pre-infarct angina is considered a clinical correlate of ischemic preconditioning. It is associated with reduced infarct size, reduced microvascular injury, and better outcome. Ischemic symptoms from peripheral arterial disease also resulted in lower mortality, probably due to remote ischemic preconditioning. Now, local ischemic preconditioning is initiated by local autocoids like adenosine and bradykinin. This acts on the sarcolemmal receptors and initiate mainly 3 signal cascades. A similar pathway, but mediators are carried to the heart by neuronal or humoral pathway activation of STAT5 appears to play a role. Now, what are the conditioning strategies? Ischemic post-conditioning. In the smaller proof of concept studies like post-MI, Ma et al., Young et al., and other side has showed ischemic post-conditioning reduce infarct size. However, larger studies like post by Han et al. And other studies did not find the similar finding. Only a small study conducted by Lombard et al. Reported the important clinical outcome in terms of reduced heart failure developing. Remote ischemic conditioning. It reduces the infarct size in all available studies, no matter whether there is patient undergoing reperfusion by primary PCI or by thrombolysis. Condi trial by Sloth et al. And another study by Kim et al. Shows the reduced all-cause mortality and less MACE. This trial is important trial of RIC STEMI trial. There is 253 participants were divided into one fashion. Study group received ischemic preconditioning for 3 cycles of intermittent lower limb ischemia for lasting for 5 minutes, and the result was in hospital heart failure and need for diuretic and inotropics were lower in the RIC group. In 12 months follow-up, EF recovery was enhanced in the RIC group. Cardiac mortality and hospitalization for heart failure was also reduced in the RIC group. But this is not the same. There are other contradictory studies also. Condi and RIC PPI trial, there were larger study population, 2569 patients in the control group and 2546 in the interventional groups. Study design: interventional group reduced 4 cycles of intermittent ischemia of the upper limb, each lasting for 5 minutes with 5 minutes before the primary PCI. A results at 12 months post PPI, there is no significant difference in the frequencies of the cardiogenic infarct site and hospitalization for heart failure. There was no effect on the myocardial infarct size as assessed by cardiac biomarker. So there are other studies, strategies like intercoronary infusion. This is the first trial, Amihot trial. The strategy involves administration of intercoronary supersaturated oxygen.
ये तो मार्च का है ये.
Study population 269 patient. Inclusion
ये तो ठीक
criteria
है, लेकिन ये तो 14 मार्च को मैंने एक महीने के लिए लिखा था. आप कभी जून में लौट के आ रहे हो.
4 hours of symptom onset, undergoing primary or rescue PCI. Study design: patient were randomly assigned to either receive hyperoxymic
थोड़ी बताएंगे तो जल्दी बताऊं आपको. आप ही लोग
or
हम लोग के क्लास में बैठे हमारे बच्चे की बात
perfusion,
नहीं.
and primary endpoints: final infarct size at 14 days, ST segment resolution, and myocardial wall motion abnormality score. What was the result? In the overall study population, intercoronary hyperoxymic reperfusion was safe but does not improve regional wall motion and ST segment resolution or final infarct size. But in patient with anterior STEMI, a possible treatment effect was observed, reperfusion with the 6 hours of symptoms. Only in anterior wall STEMI there is some benefit. From this trial, this is a important trial done by Gegstron, and this is Amihot 2 trial. Study population was 301 and inclusion criteria were MI with primary PCI performed within 6 hours of symptoms. Exclusion criteria was cardiogenic shock, recent CPR, IABP, increased bleeding risk, unsuccessful or complicated PCI. Primary endpoints was infarct size at 14 days on SPECT. Study design: study population was divided into 2:1 ratio. Those who received supersaturated oxygen therapy, arterial oxygen was obtained from the contralateral limb mixed with the liquid oxygen to achieve a PaO2 of 760 to 1000 millimeter of mercury and infused into the LED proximal to the stent for 90 minutes. Result: among patients with AMI-HEART-2 trial, supersaturated oxygen therapy was not associated with significant reduction of the infarct size, but when a positive subgroup from the overall negative AMI-HEART trial was pooled with the above study population, there was significant reduction of the infarct size. There was no difference in the overall MACE rates at 30 days. There was an increased bleeding related adverse event in the hyperoxemic group. These are the other various strategies, all on almost negative: aspiration thrombectomy, mechanical thrombectomy, endovascular cooling, deferred PCI, intra-aortic balloon pump, glucose, insulin, potassium infusion. There are some initial hype, also does not fulfill the criteria, though there is some lower rate of composite outcome of cardiac arrest or hospital mortality. GP2B antagonist also not helpful. Adenosine, erythropoietin, all are negative. Intracoronary nicotinidyl nitrate, all are negative. Supplemental oxygen therapy was also not useful. Intracoronary morphine therapy was also not negative. Among all the negative, there is some good sign. There are some positive results with atrial natriuretic peptide. According to J-Win study, ANP has shown to reduce the infarct size. Enexetide slide, this is a small study by Lombard. Enexetide was shown to reduce the infarct size. Metoprolol, there is some controversial result in the Metocard clinic trial. IV metoprolol prior to the reperfusion showed reduction in infarct size. However, early BME trial, such observation was not seen. Esmolol, it has shown to reduce the infarct size in BEAT-AMI trial. This four molecule has shown some benefit in terms of reduction of the infarction size. Now, why there is failure? The animal experiments done in labs are mostly done on the rodents with normal coronaries. Humans, on the other hand, have multiple risk factors like comorbidities, like advances, diabetes, hypertension. Patients with MI are already on multiple drugs like ACE inhibitor, beta blocker, statin, which may have their own cardioprotective efficacy. So, efficacy of the other drugs may overlap with the current medication. The temporal evolution of MI may also affect the cardioprotective protection. If reperfusion is rapid within 30 minutes, no intervention or drug will make a difference in terms of infarct size or clinical outcome. Beyond 4 hours of symptom onset, there is little salvageable myocardium. Ischemic post-conditioning entails further manipulation of the lesion and may induce coronary microembolism, which may further affect the cardioprotective effect. So, what is the future direction? Drugs targeting the opening of the mitochondrial MPTP channel are under development. Role of other novel targets the release of mitochondrial DNA, connexin 43, ATP dependent potassium channel, and STAT3, GSK3B may also be useful in future. So, initially, remote ischemic preconditioning appeared to be simple, effective, safe, inexpensive intervention, and infarct size reduction has been evidenced by many trials in STEMI patients, no matter whether undergoing primary PCI or thrombolysis. However, the results of the larger trial like RIG STEMI favor ischemic precondition, but CONDI2 and ERIC primary PCI trial did not find any significant difference. Larger clinical trials with drugs which have shown positive result initially like ANP, exenatide, metoprolol, and esmolol may be worthwhile. Intercoronary supersaturated oxygen have shown positive results in preliminary trials. Larger trials should be conducted to explore its role in preventing reperfusion injury. Thank you.
Thank you, Dr. Majumdar. You have done an excellent job on a difficult topic and covered it in time. There can be questions. I think that Dr. Shankar Mondal is ready to ask a question. Dr. Mondal?
So, in fact, there is a recent study of metoprolol. It also causes neutrophil stunning and decreases the macrophage receptors, and it is a very good drug now to some extent cardioprotection. And number 2 is neuropeptide Y antagonist. They're trying with this for cardioprotection, and trial is going on. And number 3, Dulot trial. That's the unloading of the cardiac valve, in fact, that shows to some extent cardioprotection. These are all ongoing trials going on.
Yes, sir. One trial is going on before in patients who are on cardiogenic shock put into the impeller to unload and then vascularize. That trial is going on in the USA.
Euler trial, yeah.
Yes, metoprolol has shown some benefit, definitely. So further larger trial will be needed. And GLP-1 analog has shown to reduce the infarct size. And
Nirpeptide Y antagonist.
yes, these are the so this is a potential important topic because in spite of all the adequate devascularization, if we want to protect the myocardium, some form of therapy will be needed.
Yeah, also, Vishwajit, thank you first of all for your great lecture. Very good, very nicely done. I'm Dhiman here. This sacubitril valsartan combination has shown some protective effect on the myocardium after MI, as you mentioned after SGL2, because SGL2 inhibitors has been, especially dapagliflozin, has been found to be very good following acute MI, and they can be started. But we have found that sometimes there is precipitous fall of blood pressure after initiating in these, unstable patients. You don't know with an acute anterior wall MI, all the patients, even with a infero-posterior MI. But that way, sacubitril valsartan is rather safe. And it is the only one molecule which has shown in some small studies that they prevent the rupture of the ventricle. So it's very, and of course about metoprolol you told. So metoprolol IV injection before the, even thrombolysis, because thrombolysis should be done at 10 minutes if it is done at all, according to ESC 2017 criterion, guideline criterion. And, if it is given IV, it's, it saves the muscle and the infarct size is definitely reduced. And recently also Braunwald in a lecture has told that it should be given to all the patients if there is no contraindication. They also, according to the Scandinavian scientists, they reduce the plaque size like the statins.
Thank you, sir.
Thank you very much. Thanks.
Dhiman, in sacubitril valsartan recently Paradise MI trial, it shows sacubitril valsartan in fact is not superior to ACE inhibitors. So if it is Paradise MI trial is not superior to ACE inhibitors, why do you think that is really myocardial protective?
No question of thinking. I
like
told about some of the trial data, Shankar.
Yes, sir.
There is no question of any thinking. It is evidence-based. Some small trials I mentioned.
No, Paradise MI is large trial.
No.
Paradise MI is large trial.
No. I didn't tell that it is inferior or superior to some other molecule. You are doing a mistake. I just told that this has been seen, and I would like to give some of my patient to see it doesn't prevent causes rupture, because rupture is a dreaded complication. We lost the patient. So it has been shown in some of the trials. That is what I mentioned. I didn't mention that it is better than ACI, it is inferior to metoprolol. I didn't mention all this.
Yes, sir. Just one comment, sir. That trial definitely was not able, sacubitril valsartan after post-MI was not able to achieve the target. The benefit was statistically not significant, but there is some benefit is there. But the one loophole of that trial is that dose of the valsartan was very less compared to maximum dose of NRP. So comparison dose was slightly lesser. So we do not know whether higher dose of sacubitril valsartan could have a beneficial effect or not. But definitely that trial fails to show the statistical significance, but there is some tendency to get benefit. Thank you.
That has been a nice discussion. For the interest of time, we are running slightly late. Our next discussion is Dr. B.B. Bharti. Is he there, Dr. Bharti?
He is facing some problem with the network. He is facing some problem. Yeah, yes. I think you can start. He will be joining soon.
It will be me. Okay. He will be joining soon. Okay. Oh. Sure. Oh, no. Can you see my slides?
We can see, sir.
Yes, yes, yes,
Can you see my slides?
yes.
Okay, fine.
We are able to see.
Okay. It's all right. Okay. My topic is cardiogenic shock in myocardial infarction, role of mechanical circulatory support. I'll be dividing my topic into 4 parts. What's the definition of a shock? What's the epidemiology? How to treat? And what are the advances? The definition is everybody knows that it is defined on a clinical and hemodynamic criteria like systolic blood pressure less than 90, supportive measures needed to maintain blood pressure, end organ hypoperfusion, cool extremities, urine output less than 30 per hour, and heart rate more than 60. Associated with hemodynamics of cardiac index less than 2.2 and PCWP more than 15. Recently, SKY has staged cardiogenic shocks into 5 groups: stay at risk, beginning, classic, deteriorating, and extremist. And mortality increases with the increasing grade of the shock severity, starting from less than 10% to up to 80%. And there is an increasing prevalence of acute myocardial infarction with cardiogenic shock, which is gradually increasing. It happens 10% in STEMI, and nearly 3% of the STEMI are complicated by cardiogenic shock. And it remains high in hospital mortality of approximately 50%, and ongoing hazard post-discharge can go up to 10% after discharge within 60 days. What is the treatment of cardiogenic shock in myocardial infarction? Of course, it is revascularization of the culprit lesion only. Immediate revascularization of the culprit lesion will save approximately 10%. But if you go for multivessel PCI, then the all-cause mortality or renal replacement therapy requirement increases by approximately 10%. So the current recommendation is this, that we go for culprit lesion PCI only. You are getting me? Culprit lesion PCI only. And only in exceptional circumstances, you can go for multivessel PCI, like when you have got a co-primary lesion. So after you have done a PCI, you are still in trouble. We are thinking about giving some support to the patient. Several kinds of devices are available. I'll be concentrating mainly on the 3 devices, 2 of which are readily available in India right now. One is IVP and 2 is VA ECMO. Impella is there, but I think it is out of not available in Kolkata. I don't know where in India it is available or is routinely used. If you look at the technical properties of these devices, IVP increases, has got a modest support of 0.3 to 0.5 liters only, but it increases the cardiac power output and decreases the afterload and increases coronary perfusion. If you look at the ECMO, it can give you a very good support of 5 liters or more. Cardiac power index improves, but there's a big but. It increases the afterload, so that can lead to LV dilatation, and it has got no effect on coronary perfusion. Impella can give you a cardiac support of 1 liter to 5 liters. Cardiac power output improves, afterload decreases, coronary perfusion increases. But what about the results of the trials of different mechanical circulatory support systems? IVP shock I1 and IVP shock 2, both the trials have failed to show any survival benefit with IVP shock 1 and shock 2 up to 30 days. And up to 6 years, and IV62 follow-up recently published 6 years, there's no survival benefit of IVP used in AMI shock. But IVP2 trial gave us an excellent scoring system of 6 variables, total 9 points. If the scores is low, that is 0 to 2, intermediate 3 to 4, and high 5 to 9, as the score increases, mortality increases stepwise, and you can triage your patients according to the score. If the score is low, you could go for a basic simple therapy. And if the score is high, you have to think about advanced therapies also. The impella is being talked about everywhere. The FDA indication for impella is treatment of ongoing cardiogenic shock that occurs immediately, less than 48 hours following acute myocardial infarction or cardiac surgery as a result of isolated left ventricular failure, which is not correct. These days, that is not responsive to optimal medical management and conventional treatment measures with or without an intra-aortic balloon pump. Theoretically, hemodynamics looks excellent. It improves cardiac output, improves flow, increases mean arterial pressure, decreases left ventricular end diastolic pressure, decreases left ventricular end diastolic volume, increases oxygen supply and reduces oxygen demand. All very good. But the results, there have been several randomized trials, small trials. The ISR shock, only 26 patients were randomized. It was a very flawed trial with a very unrealistic endpoint goals. But anyway, though the cardiac index improved slightly compared to IBP in the impella group, the 30-day mortality was no difference. And there's another relatively newer trial, that is IMPRESS in acute shock, which randomized only 48 patients to either impella or IBP. The primary endpoint was 30-day mortality. There was no difference. 6 months mortality was no difference. Again, the outcome, the primary outcome endpoint was very unrealistic. That it was thought that it will reduce the 30-day mortality from 95 to 60%. 30% mortality benefit was expected in the trial design, which is not really true. What is the registry data about this impella? This is a propensity matched NCDR study in which approximately 3,000 plus patients, 3,500 plus patients were randomized, 1,060 in each group, in hospital mortality and major bleeding. There is a higher absolute rates of in-hospital mortality and major bleeding amongst patients treated with impella. So that is a very serious observation, that if you get a given impella, you are looking at higher mortality and higher major bleeding points. And these results are consistent across multiple sensitivity analysis, whether stratified by timing of a device placement before initiation of PCI or after initiation of PCI, whether limiting to hospitals that are experienced, whether excluding transfer patients. So that in the real world, the impella was associated with the significantly higher rates of in-hospital death and bleeding compared to IBP. And the last device that we'll talk about, which has been in news recently because of entirely different epidemic which is devastating our lives, COVID, is the ECMO, extracorporeal membrane oxygenation. There can be two types, VA ECMO or VV ECMO. There's no randomized trial on ECMO. There are only some observational data and a registry data in which also registry which has got a large database of AMI cardiogenic shock. And 5,890 of non-AMI cardiogenic shock were analyzed in the also registry. Survival to hospital discharge was not different in the AMI cardiogenic shock and non-AMI cardiogenic shock groups. But there is a key finding. Also registry in a key finding stated that patients receiving VA ECMO support for cardiogenic shock in the setting of acute MI did just as well as those who got it for other indications. But the likelihood of death arose when cardiac arrest entered into the picture. So that in a patient, if you are destined to get an ECMO, go early before the patient arrests. So what do the guidelines say? Guidelines, if you look at the ESC guidelines, short-term mechanical support may be considered in patients with refractory shock. It is class of recommendation 2B, level of evidence C, that is expert opinion only. There's no data as such. But there's a large number of trials that are being done with the defined kind of cardiogenic shock patients with the defined devices and defined combinations like BA ECMO, IBP, Impella, BA ECMO, ECMO plus RT, all these things. There are roughly 10 or 11 trials, but none of the trials data are available right now. So the definite recommendation, yes, it does not have got a definite recommendation. What about the American in STEMI 2013 recommendation? Alternative LV assist devices for circulatory support may be considered in patients with refractory cardiogenic shock. Again, class of evidence, level of evidence is to B, class of recommendation C. And in 2014 ACC/AHA guidelines for NSTSS, it is reasonable to use IBP for refractory shock. It is class 2A, level of evidence C. But they do write without any recommendation if there is a large amount of ischemic territory and very poor LV function, percutaneous ventricular assist devices, or in less severe cases, an IVP can be used for support during the procedure. So what do you do as a treating doctor? This is a very important step. Look at the FNN, a cardiogenic shock, a multidisciplinary heart team consultation like interventional cardiology, surgery, intensivist. If the patient in pre-shock and then dynamics, escalate if necessary. If the patient is in severe shock with either hypoxemia, biventricular failure, or RV failure, if there is no such indication, then after analysis of the femoral angiography, you can consider an Impella. Remembering all the caveats that was there, that no real benefit has been shown in any of this. But I will live with this observation of mine, that lack of evidence of benefit is not the same as evidence of lack of benefit. Thank you.
Excellent lecture. Yeah. Excellent lecture, DP. Very good, very informative lecture. Just to tell one thing, DP, you know, this trial which was done with Impella, this was with 2.5 Impella. At present, I think 2.5 Impella is not in use in US, and they're using all Impella CP, which is 3.5, even they're going for 5. So the capacity is much larger. And there are two trials, Protect 2 and Protect 3. Protect 2 didn't show any positive result. Protect 3, little bit, but no reduction in mortality. And Protect 4 is underway with ECMO, with Impella 3.5. So this will be very interesting to see the result of Protect 4. Thank you.
Thank you, sir. I have a question to ask. The Impella results in cardiogenic shock. Protected PCI was done in those patients who had PCI on.
These are done in high-risk PCI patients, not in
high risk patients.
Those were not cardiogenic shock patients.
They are not in cardiogenic shock.
Impella in cardiogenic shock, we have got discordance in the results of registry data. Registry from.
Dilip, I think the audio is disturbing a little. Is the audio okay with you all? Or is my personal audio disturbance?
No. Audio is disturbing. Audio is disturbing.
Audio is disturbing, no? Right. Yeah, audio. Dilip, can you ask Raghu to look at it? Audio team, please look at it. Audio. Because I think there is some disturbance in the audio.
Because of your bandwidth, actually. If you really want to have good audio quality, you'll have to stop your video, then go on giving the speech. That's how the things are improved. The bandwidth is lost when the video is played.
I was telling.
But we want to see each other. If the video is closed, how can we see each other, Mrinal? And all our meetings, we go with video on.
That's right. That's the problem. But
I would like to see my friend Mrinal, Shankar, DP, Dilip Kumar, everybody.
Your voice very nicely.
No, it's coming very nicely. but sometimes it's coming not very nicely. That's the problem. Therefore, I asked whether it's my problem or it's a common problem.
It's a common problem.
Yeah. Okay. Okay.
Okay,
So,
Dilip,
Raghu, please see to it. Raghu, I think you are listening to us.
Yes, yes. Sir.
Dilip, next speaker.
We have some time for discussion. Dr. Bharti is facing some network problem. I was referring to in the randomized control trials of Impella in cardiogenic shock. 50% of the patients were out of hospital, but it's we expect kind of higher mortality.
Oh, no, yes.
And new trial which is going on, that is Danish in Germany.
Yeah, there's a lot of trials going on in these kinds of patients, but that's a list that is published by the ESA in 2020. None of the trials are completed. Later on, the results be available in the public domain.
Only the Impella is done.
And there are various kinds of recommendations, combinations they are used. They are using Impella with ECMO, so-called as ECLA, right? And ECMO with Impella with IBP, all those things. You have ECMO with RRT, the dialysis to reduce the preload. They're doing everything. They're doing IBP with ECMO to reduce the afterload, because ECMO always increases the afterload. And as I said, that increases the left ventricular volume. It can cause ballooning of the ventricle. So we are trying to put in ECMO, IVP with ECMO.
Yeah, Impella is coming in a very big way, actually. One of the causes of cardiogenic shock is definitely right ventricular failure also. Right ventricular decompensation really contributes to a great extent to the left ventricular function. Now, what happens in this scenario, Impella on the left ventricle is not going to help unless and until you give adequate volume to left ventricle with the help of right ventricle. And that's why the right ventricular Impella is also coming in a big way. And we have been demonstrated by Dr. Subhash Bandyopadhyay in a beautiful presentation in last NIC meeting. And really, Impella's future is quite good, but the only limiting factor is cost.
We have Dr. KD.
But Das.
Yes, yes.
We have Dr. KD Singh in expert panel. We can have it.
Okay, Dr. KD Singh. Okay, now Dr. KD Singh, you can start.
Hello.
Hello.
Yeah, good evening, everyone. Really, the talk was very informative, and thanks for such in a COVID era when we are not having any conferences. This live conference is going to help us. So far, in peripheral area, we are using only IABP and ECMO in recent area because of the COVID. We are getting the support, but basically, it is the apart from this circulatory assistant devices. We need to have the infarct artery to be open as soon as possible, because unless we didn't restore the blood supply to the myocardium, because these are the just devices to give you a time. In the meantime, you can do the proper treatment. So the first thing is that the duration, how long is the time, because the most important thing is that the patient when come to you from the time of the ischemia, as the patient will present late, the things are going to be very difficult. So apart from these devices, I think that the patient awareness must be very most important thing, because many times it is the patient who present to us very late and the problems are multiplying. And in spite of our all efforts, we do all the things and we lose the patient. So I think it is the patient awareness, so that they should reach the hospital in time. So because the time of the shock from the onset of the symptom is very important.
Yeah, Dr. Singh, you have got a very valid point that the patient symptom onset to hospital contact is very important. And thing is, the symptom onset to first medical contact is one of the most important areas where we are still lacking, because we don't have any national ambulance policy or things like that. But in some areas where it is available, or either on a pilot basis or on a treatment basis, like they are getting good results. But,
Sir.
and the public education, public awareness program is part of the job of CSI. And I think CSI initially had taken some initiative, but after that, Corona came and for 2 years we were able to do nothing about that. Once the Corona epidemic is over, I am sure Dr. Debrata Rai and the team will take a good care of it. We had some discussion regarding AMI, like spoken hub system management in Kolkata also. I even
Right,
also
sir.
attended a meeting from Delhi, but really nothing came out of it. Everybody has gone to back burner.
Sir.
And regarding the RB shock, what Dr. Das was said, the thing is this, we don't have an Impel RP, but definitely we have an ECMO, which is equally good. That a BV ECMO could be very good here.
Early institution of Impella is going to make this.
Sorry, Dilip, not getting you properly.
I think we can move on with the next presentation. You can call Dr. Harish Mehta for the next one.
Dr. Harish Mehta, is it there?
Yeah, I'm there.
Yeah, please.
Thank you. Thank you, Dr. Dilip Kumar, Dr. Sikdar, for having me over.
Multivessel disease and stage PCI. When?
Okay, I'll just start sharing my screen. In the meantime, thank the organizers, Dr. Dilip Kumar, Dr. Sikdar, for having me over. We're going to talk about a very complex topic, which is about multivessel. How do you handle multivessel in the setting of acute MIs? And that's a huge topic. I'll try to do it as fast as possible in the time permitted. So we know that it's about 30 to 40% of STEMIs have multivessel diseases, and it causes increased risk of morbidity, mortality. There is lack of compensative hyperkinesia. The reserve is low. There's increased inflammatory response, and it's also a marker of extensive atherosclerosis, which is a marker of bad prognosis. An average number of lesions are 2.4% per patient. It's the NHLBI data, and the number of stents are 1.3 per patient. And 86 to 90% culprit only PCI has been the target. So non-culprit PCI in STEMI, which used to be a class 3 recommendation up to 2013, had moved to class 2B in 2015. And it was upgraded based on number of data trials that came in. And this was happened in ESC 2017 when the recommendation changed from 2012 to 2017. What it said, that complete revascularization during index primary PCI and STEMI patients in shock. Again, we will have a debate on this later. So we will go further. What are the advantages and disadvantages of multivessel PCI at the same time? Of course, the advantage is complete revascularization. You treat ischemia at a distance. You treat ischemia secondary to unstable lesions, which may not be limited to the infarct-related artery. And of course, patient preference and comfort, but that would be the least. But there are lots of disadvantages because you have increased contrast load, risk of contrast-induced nephropathy, radiation exposure, complications. If one stent closes, you might have a fatality. And general clinical and hemodynamic instability, risk of stent thrombosis increases, especially if patient is clopidogrel resistant or intolerant. And the flow thrombotic and inflammatory and coronary spasm may be also a reason. So this is the strategy with its pros and cons. If you see culprit vessel PCI, the pro is reduced contrast volume, reduced risk. And the con is increased repeat revascularization risk and potential reduction in LV recovery. Whereas multivessel primary PCI does have decreased repeat revascularization, decreased hospital length of stay. But the cons are much higher. Procedure time is high, contrast volume is high, increased peri-MI risk, and potential PCI of unnecessary insignificant stenosis. And the third is stage PCI, which is another concept of doing a stage angioplasty in the same hospital admission. Here, the advantage is you have time to assess the benefit versus risk of the non-culprit vessel PCI. And the other risk is that you have an additional PCI excess risk and additional procedure cost. So do patients have events after primary PCI? That will decide what we need to do. And concept has been that multi-vessel PCI is done to prevent events. So look at this small paper that came in 2010, where they did preventive PCI versus stage preventive PCI. And they clearly found that the cardiac death MI was less with immediate preventive as well as staged PCI. But again, this was lack of statistical power and it relied on repeat revascularization, so there was bias. Then came this meta-analysis of complete versus culprit only revascularization for patients. And there was a trend towards improved long-term survival when done during the indexed PCI. But studies were heterogeneous here, so survival benefit probably was better when staged. This is the outcome of this meta-analysis. It told us that overall staged multivessel PCI did improve short and long-term survival and reduce repeat PCI. We needed more randomized trials at this time. The first trial, that was the PRAMI trial, the randomized trial of preventive angioplasty in MI, where they had 465 patients. They were randomized to infarct-related PCI to receive complete revascularization or culprit only. Non-infarct-related PCI undertaken at index PCI. Primary endpoint was cardiac death, non-fatal MI or refractory angina. And secondary endpoint were the individual components of primary endpoint, non-cardiac death and repeat PCI. And the mean follow-up was 23 months. And if you see the data, the death from cardiac cause was significantly less. The death from any cause, cardiac, non-fatal MI or refractory angina, was less with preventive PCI. So all these parameters went in favor of a preventive PCI. And that you see, patients without primary outcomes were better in patients with preventive PCI. So this trial gave a push towards preventive PCI during index hospitalization. But there were a lot of limitations of PRAMI, which were really studied later. One, the trial was stopped too early. There was no stratification for the lesion site. And there was inclusion of all angiographic severe stenosis, less than severe stenosis both. So there was no demarcation of 70. Anything more than 50 was included. And non-infarct-related PCI only performed at the index time. There was no stage procedure. And randomization occurred after infarct-related PCI. So there was potential selection bias. And patients with the infarct-related arm had more diabetes and anterior MI. So obviously they would have worse outcomes and less detailed definition of repeat MI used out of 14 days of index procedure. Then came this CVL study, which is called the Culprit Study, which is a UK open label randomized study, compared treatment of IRA with complete reversal index admission. So this was not at the same time, but at the index admission. And randomization was stratified as per site of infarct and also symptom onset to balloon time. There were 298 patients, and it compared complete versus incomplete, but during index admission. And the first outcome, MACE, was total mortality, recurrent MI, heart failure, and ischemia-driven revascularization at 12 months. The inclusion criteria are as simple as that. There's nothing differently. But the important thing is, the non-infarct related artery had to be a major epicardial coronary artery or a branch more than 2 millimeters, and it should be suitable for stent implantation. And the lesion had to be 70% in one plane, or more than 50% in two planes. Of course, cardiogenic shock and prior CABGs were all excluded in these trials. And they found the MACE rates to be lesser in complete revascularization. Components were less. And this was very clearly seen. The MACE outcomes were less in complete revascularization compared to infarct-related artery at 30 days. And this was maintained at 12 months. It clearly demonstrated 55% reduction in MACE in those patients presenting when non-infarct-related artery is also treated on index admission with no adverse safety signal. And of course, it indicated that in-hospital treatment of non-infarct-related seen during PCI resulted in improved clinical outcomes. This suggested that this strategy should be considered for future STEMI guidelines. Then came a very important dynamic 3 Premier study, which showed in these patients using the way of FFR. So I'm not going to go into details of the study. So that 627 patients were randomized with infarct-related PCI, or the other half were FFR-guided complete revascularization. And these were the endpoints: the all-cause mortality, non-fatal MI, ischemia-driven revascularization, assessed when the last included patient had been followed for 1 year. So here also you see the composites were better for complete revascularization, in revascularization also. But the main thing was driven by revascularization because the non-fatal MI and all-cause death remained the same. So complete FFR-guided revascularization told us that reduced the primary endpoint of all-cause death, reinfarction, and repeat. However, the reduction in these patients was driven only by repeat revascularization, and not by hard endpoints like cardiac mortality or cardiac heart failure. Therefore, although complete revascularization should be recommendation, any condition that makes complex PCI unattractive or dangerous for the patient, it supports a more conservative strategy of IRA PCI. Then this is the meta-analysis which came in 2018. It showed us in 2017 in JHCC by Deepak Bhatt and all. They also suggested that the risk of all-cause mortality and spontaneous infarction is not different among various strategies of multivessel disease. Complete revascularization in the index procedure or as a stage procedure was associated with reduction of MACE, but this was mainly driven by repeat revascularization. It was not driven by mortality benefit. So is it still a great taboo? Is it a taboo that the great taboo non-infarct should not be touched during primary coronary intervention? Should we do immediate versus stage preventive PCI? This needs to be answered. And then came the complete trial, which came in 2019 in 3,900 patients with STEMI and multivessel disease. They also compared culprit vessel versus preventive PCI versus multiple PCI, stage PCI on the background of optimal management treatment. And they concluded whenever feasible, complete revascularization with PCI can significantly reduce the combined endpoint of death and MI. Complete revascularization performed during PCI was also associated with significant reduction in both total mortality and MI, whereas stage revascularization here did not improve these outcomes. So they were in favor of doing a PCI all at the same time. Then that's why this is a very beautiful slide which makes it much simpler. What it says, the science and art of decision making in STEMI. So if you have hemodynamic instability, if you have ongoing ischemia, you have an uncertain culprit lesion, unstable appearing non-culprit lesion, if all the answers are yes, then you should do multivessel PCI at the time of primary PCI. If you have an uncomplicated PCI of an infarct-related artery, you have anticipated simple PCI of non-culprit lesion, and if you have absence of chronic kidney disease, if answer is yes, you do at the same time. And finally, if the answers are no to this, you defer it, and then you can stage it or ischemia guide it. So this is the summary.
10 minutes time 13 minutes video on this, so 17 minutes per time.
Am I continue to speak or there's some interference? Hello, can I speak?
Yes, sir. We have 2 more minutes.
Yeah, sure. So in summary, it tells us that multivessel PCI in stable patients with STEMI is safe. You can stage it depending on the algorithm I gave you. But the important thing which was also mentioned, I'm not going to go into detail of that. The culprit shock, which people expected that you should do multivessel PCI at the same time of primary PCI, in fact showed us that you should do culprit only visualization during the index procedure, which is complicated by cardiogenic shock, and the other vessels should be done as per needs. So there's an art as well as science to treating these patients. You should not have a generalized management based on the randomized control trial. You must instant tailor therapy for each patient, incorporating clinical features, angiographic findings, and patient preference in our decision making. Thank you very much.
That was an excellent presentation from Dr. Mehta. I think we have got a couple of minutes of time. If there's a point question, Dr. Mandal, you would like to make some observation? Dr. Mandal? No. You want to make some observation?
Dr. Dilip, can I come in?
Yeah, Sanjeev, please, please.
Yeah, see, the whole concept of this multivessel versus stage versus the culprit started with the PRAMI, and with the dynamic trial and the compare acute trial, they came up with the concept of FFR in the non-culprit artery. And now the complete trial didn't have that, but now with the FLAR AMI trial which has come up, it really shows that the concept of doing FFR in the non-culprit lesion is equivalent to just having the angiography. In fact, you have the problem with the dynamic compare work. If FFR positive, you're doing it. Otherwise, you're keeping on medical therapy. The FLAR AMI side, you have graphically, if you have a if you think it's a stenosis, you go ahead and do it.
Yeah, I think
the controversy still says, because the basic concept is what are you considering as culprit only? The staged procedure means in the index hospitalization. Are you taking that into consideration as complete revascularization, or once you're doing a stage procedure also, you're taking it into a culprit lesion only. That confusion still stays. But with the FLAR AMI trial telling us, of course, FFR of a culprit lesion is not to be done. But if the FLAR AMI telling us that if you have an angiographic lesion, which is very clear, then the risk of intervention is equivalent to not getting it done later. So the problem still stays, and this is all in acute MI. This is nothing to do with non-STMI. So a recent trial came with non-STMI also, where they have not told us how did they identify the culprit lesion. But the end result is that yes, doing the non-culprit lesion also in the index procedure is better. So the debate will stay till we define what is the role of FFR now remaining in non-culprit. The debate still says whether what is our definition of index the culprit only lesion. Is it that if somebody is admitted in the index procedure, 3 days down the lane you do his other artery, is that culprit only artery or is that a stage procedure? Those definitions still nobody has made clear. So these contentious issues still stay. So they were in the PRAMI trial, these were the drawbacks. They didn't have anything to do with, they just took up LAD more than any artery more than 50% as their lesion. But then when FFR has been done, that also so now we have come back full circle back to angiography. Yeah. But again, culprit shock trial is about cardiogenic shock. So the concept about multivessel in acute MI without cardiogenic shock and clog is there. The present consensus is if there is a cardiogenic shock, do only the culprit only lesion because of the culprit shock trial. But then there is a Coronary registry which is absolutely opposite to it. Once again, because they are not including the index procedure, they are differentiating the index procedure from the index lesion. That means if you've done it once, the Coronary trial, if you've done it after 3 days, is including it in the multivessel registry. So I think the gray zone is what is the index procedure, and the gray zone is whether we are still taking FFR into picture. The complete trial never took FFR. There were only 13% people don't have FFR.
You see,
back to our angiographic instincts.
Hello.
Yeah.
FFR is always underestimate the lesion. That's why FLAW trial is almost negative. In fact, if you want to treat all the vulnerable plaque, then you have to do the imaging. It is very difficult, you know, that
see the role of FFR being underestimating is with respect to the culprit artery, not with respect to the non-culprit artery. Your underestimation or over, because you will have a microcirculatory failure, so you'll have a falsely high FFR value and give it a norm. That is for the culprit artery, not for the non-culprit artery. So the whole concept of FFR being not getting into, but the point is the wheel has taken a whole spin because you've come back to angiography. The flower AMI trial says that you just take it as an angiographic criteria and go ahead, and the results are almost the same.
Right. I think we have got a complete
better with the multivessel.
Dr. Kathuria, we have a complete U-turn in this regard. In 2000 till 2008-9, there was a consensus that in cardiogenic shock you do all the vessels.
Yes.
There is no cardiogenic shock, do only infarcted vessel.
Yeah. Absolutely U-turn.
U-turn we have.
Reversed.
Yeah, it is all because of culprit shock and PRAMI trial. And this is exactly what we have seen. We have seen a patient with a heart rate of 120 and a BP of 90. We have done an LAD, and as soon as we touched the right coronary artery of 90% lesion, the patient collapsed. So this we have seen, and I think thankfully we are in the right direction. And with the availability of these trials, we are going in the right way.
I think, Dilip, the question stays in a non-STMI. I don't think so. Controversies are lower. I think in a non-ST, you should go ahead, do the complete revascularization. It's about the STEMI and cardiogenic shock with STEMI, cardiogenic shock without STEMI. It's different. The consensus around is without shock, you go for a multivessel. But what is the definition of multivessel? In the same setting or in the same index procedure? What is your view about that?
This is same. The trials have shown that if you do it on the same sitting or before the discharge, it carry the same significance. So there is no difference. Means revascularization, complete revascularization means we have to do the revascularization in non-cardiogenic shock patient before the patient goes home.
That in a non-cardiogenic shock seems solved, but with the cardiogenic shock, the Coronary registry and the culprit shock trial are going in the opposite direction because they are not for a cardiogenic shock. The Coronary registry is saying even if you're doing it in the index, the hospitalization after 3 days, it's a multivessel. It is not complete revascularization. It is a stage revascularization. So the spectrum for them is still in the gray zone.
Dr. Dilip, I think we have got a very beautiful discussion, and since we are at the end of our time also, I think we should proceed for the next session. Over to you, Dr. Dilip.